Good afternoon again. Well, good evening now. If you would place your name and campus back in the chat again, your name and your campus. The exam analysis will take place on tomorrow morning. Grades should be posted by no later than noon tomorrow. Hopefully earlier than that, but grades will be posted no later than noon on tomorrow. Just as a reminder, all these sessions are recorded. Make sure that your screen name shows as it appears on the roster. All right, so let's look at where we're at and where we're going. So this is week 4. So week 4, and I'm pulling up, share my screen here in just a second. So week 4, we're looking at, all types of communication, but just be thinking about how important communication is and what are all those moving pieces and parts that actually make up communication. We might not have thought about, there's a sender, there's a receiver, then there are different types of communication. Is it effective communication? And the things that communication can help, are there barriers? Are there positive techniques to communication? So I think we have everyone in now. Again, good evening. Welcome to week 4. The exam analysis will take place in the morning. So grades should be posted no later than noon on tomorrow. If you would place your name and campus in the chat. And as always, these sessions are recorded. If you check your screen name, make sure that it appears how it appears on the roster. Okay. All right, so now I have the modules pulled up here. We're in week 4. Place your name and campus in the chat again for those of you that are just coming in. Okay, so we are in week 4. Hold on, it's not showing all the way. Let me stop again and share again. Okay. Okay, week 4, we're discussing communications. I just mentioned, we might not have really thought about there's a sender, there's a receiver. There's so many moving parts to communication. There are barriers. There are things that can facilitate or promote communication. Communication can be ineffective, it can be effective, and there are different types of communication. And so we're going to talk about that in just a moment. I'm not going to give it away here. So we got communication. We're going to be looking at the different people on the healthcare team. And then on next week, we have the healthcare team again, and we're going to be looking at more about delegation and more about leadership, and then collaborating with those more specifically on that healthcare team. Is communication important when that person is changing settings? And that could be if the person is leaving the emergency room, going to mid-surge, if they're being discharged from the hospital and they're going home, being discharged and they're going to another healthcare facility. Is what being communicated, is that information important? Does communication needs to take place? Okay. So I have sent, let me pull this up here. 3 slides to your Canvas mail here, and we'll look at those in just a moment. So when we talk about mandated reporting, so in the chat, I'm going to use chat for this one. A one-liner, two-liner, we'll give you 2 minutes to respond. What is your understanding of a healthcare professional when we're talking about mandated reporting? Let me share my screen. So in the chat, what is your understanding of the healthcare provider, the nurse, the person that is that healthcare provider? What does mandated reporter mean to that nurse, to that PN, that RN, to the healthcare provider? And then send your messages out so that everyone can see, because we do know that we're pretty much all going to say the same thing, but when we see it, reword it, paraphrase, it is going to layer our foundation, our understanding. So 1.5 minutes. Okay, let's start seeing what your responses are. Mandated report. When you hear that word, what comes to mind? What is your understanding? We're obligated to report abuse or neglect because we are legally obligated. Okay, accurate reporting. Do we have to confirm or know all the facts? Do we have to know all the facts when we're reporting?
No.
Okay, good. And someone mentioned neglect and abuse. So what is abuse? So when we're talking about mandated reporting, just think about it. There are many forms of abuse. So what are some examples of abuse? Someone said neglect already.
If we
What
see like bruises,
Sexual
different
abuse.
shades,
Verbal abuse.
we do want to hear from each of you. Whoever was speaking, you all just take turns. Go ahead.
like if we see different shades of bruises on a person, like different stages of healing when it comes to bruises as far as like physical abuse.
Especially if there isn't a reason or a cause. So what would be a cause that someone would have a bruise on them?
If they are a combative patient, like some ones that got dementia, sometimes they fight you and stuff. So they may, you know, some I'm not saying that you're gonna abuse them. I'm saying there are the people that sometimes have extra bruises that you look at.
They shouldn't
Medication.
though. They shouldn't. Think about what we just said. If we know that they're combative, what is our approach? If we go in, knock, knock, ma'am, sir, in 201, we're here to provide you your bath. And they frown or pull away. Do we continue with whatever we went in there to do? What's the approach?
Oh, I misunderstood your question. I thought you
Give
said
them a
signs of
space
abuse.
and let come back later.
Leave them alone. So they shouldn't be, even though someone is combative, our approach should be leave alone, switch persons that's working with them. So that shouldn't be. So in fact, if they are combative and people and their family members do see bruises on them, they're going to think that the healthcare professionals are actually hitting them back and really not leaving them alone and reapproaching as the interventions are saying. So what would be a reason why? So we see bruises on someone, but what will first come to mind? They probably had these bruises because what?
They
This,
fell or somebody hit them. They got burning. They burn them in hot water intentionally.
but I guess I'm not wording the question correctly. So first off, we would think someone would not cause this person harm. If they're in the care of healthcare professionals, we would think that no one's causing them any harm. but they still have bruises. What could be a reason that would justify that they probably have
Medication that they're
Yeah,
on, like if they're on
medication.
blood thinners.
medications, previous injuries, some bleeding disorder? I'm looking at the chat now. Yes. So initially we would think, because we're not there to cause them any harm. So hopefully there's some justification. They're on medication. They have some bleeding disorder. They may have had a recent fall or something like that. And that's why it's so important that no matter how big or small or how minute instance is, we want to make sure that we're capturing everything that our patients, our clients, our residents, that they are doing. So someone mentioned someone being combative. What if we have a patient, they're at the door, that they're in like the locked unit or a more supervised unit, and they're at that door, hitting on the door, knocking on the glass continuously. Is that something that we need to document or capture in that nurse's note anywhere?
Yes.
Exactly. Because more than likely, if they continue, just think about your hands, your knuckles, your arm, if you're continuously pushing up against something, more than likely, what's going to be wrong with that hand or that arm?
Come broke or you got
Bruising,
bruised.
bruising, hurt. They're going to be complaining of pain. It might even be difficult to even move that extremity. So we do want to capture all of those things, because in the event that we do find bruising, the first thing should be, we didn't cause any harm to this patient. What could, be the cause of this? Not that someone hurt them, but something may have occurred or is occurring. This blood disorder. They're on some type of medication. Their behavior, whatever they did the hour prior or the day before. So we do want to capture all of that, because we are mandated reporters. We don't know. So another question I asked you all, do we have to confirm and know all the information to report, to be that mandated reporter? No. But if we have suspicion, we do need to go ahead and report that. And so there is a process. There's a team of people that will, gather all that information and hash all that information out. And hopefully the findings are that, a healthcare professional or a loved one did not, in fact, cause that harm. But we just talked about physical abuse. What about we have a family member taking care of their family member, and the family member sent them to the store to buy, I don't know, set things on a list, and they come back, they don't have any of the items on the list. They have paid their light bill, their card note, their credit card bill. Is that something that we need to be reporting as well? So yes, that's a form of abuse. That's that misappropriation of funds. For some facilities, they even call and report the hospital or the long-term care facilities, because they're saying that those facilities have misappropriated their loved one funds, their finances. So we don't have to know all the detail, but if there is some suspicion of abuse of any of those types, we do want to make sure that we are reporting that. Okay. All right. So active listening, the most important part of communication. It says particularly therapeutic health related communication. We want to start uh, those therapeutic relationships with our clients from the very first time we meet them, making sure that we're introducing ourselves, because we're the person that's going to be coming up with collaborating with that registered nurse with those interventions, deciding what's important, what's our plan to take care of this patient, to provide that best care for their patient. And we don't want the client or the patient not to give us information. We want to find out what they value, what they know about the disease process. So establishing those therapeutic communications and relationships early on is going to assist us in providing that best care for our clients. Therapeutic communication is the interaction between the nurse and the client, focusing on the client's physical, emotional, all things, all those moving parts for a person, thinking about all of that. These interactions require us to use effective communication strategies to provide support to the client. And we have a slide here coming up of some techniques and information and how we can reword some things while we're having those conversations with our clients to make sure that we are gathering the correct information from them. So key factors in active listening. What's the purpose? Discipline, attention. We want to make sure that we are giving them our attention because not only should we be listening to the client, why is it important that we're looking and observing that client as well?
Because
Make
it lets
sure
you know that we're paying attention.
We're paying attention, and what else?
And
making sure we see if they have any bruises on them.
Okay. And also think about it. Sometimes the person will be giving us what they think of what the answers that we want to hear. But if we are observing them, we're looking at them, we can see if they are actually have those nonverbal cues. So communication, it includes verbal, but it also includes those nonverbal cues. And if we are getting information verbally, and then those nonverbal cues, they don't match up. For example, we're going in, we're interviewing a client, and we're asking them about their pain. And they're saying, no, my pain's a zero. But looking at them, they are grimacing, they're guarding, they're frowning up. That doesn't match what they're saying. So it's a clue for us. Either they might not understand what we're asking them, or they just don't want to say that they really are in pain. But we would know all of that, the nonverbal and also the verbal information that we're getting. Okay, so we're going to pause here. You have 3 slides, but I only want you to focus on one slide at a time because it's very important that we really understand this information so that we can apply it when we see test questions on the NCLEX, on the HESI, and on the unit exams. So active listening techniques lets the person know, I am listening to you. So we want to define, discuss, and come up with some examples. We're going to give you about 3 or 4 minutes to talk through these right here. We're going to put you in groups of 2 and just do some jot noting. So when you come back, you can share out. So listen to each other, collaborate, and then you just come up with, your answer for what restating is, what clarifying is, what reflecting is, and what paraphrasing, and so forth and so forth. So these 3 slides are in your Canvas mail, but we're only focusing on this one slide. So I'm going to stop sharing, put my timer on. We probably just only need about 4 minutes to talk about this slide. And you decide on how you all want to collaborate and talk about those concepts. So when we come back, we are ready. Okay. So the break rooms are open, accept the invitation. And we're only talking about that one slide for right now. Give you 3.5 minutes. And then we'll bring you back. Okay. Rooms are open, accept the invitation. Those slides were sent to your Canvas mail. Just look at that first slide when we hit start.
I'm sorry, I didn't hear you.
I said I gotta look and see what slide we was on. I know it was
It's the very first one. It's the first one.
Okay, let me see.
Mm-hmm. Anderson, you should have received a join me.
I did, and then everybody jumped out. So now I'm just down here by myself. I had 2 different people in the group. First it was one girl, then it was another girl. Now I have nothing.
No, we were all in the main room. So you should have.
Yeah.
There are only 2 people in the room.
It was one person, and we were together, and then she left. And then I saw you and another girl, and she left. So now I'm just here. I don't know. I joined the room, but I don't know how to get back in there.
Okay.
So I don't know. Then I was trying to see the slide, but I don't see it anymore either. So I was trying to pull it up on my phone so I could do it by myself.
Two.
Where's the
Hey.
slide, Dr. Ford?
In your Canvas meal.
Oh,
In my
and Canvas
canvas
mail.
mail. Oh, oops.
Oh, okay, there you go.
Okay, we
And it's the
got it.
Thank
very
you.
first one. It's the very first one.
Uh,
And for reinstatement, I put for reinstating, I put active listening.
I'm oh I'm okay or whatever because I don't know, I got ice cream today or something. Then you'd be like, so you're okay because you got ice cream today.
Oh, yeah, something like that. So
Uh
you got ice cream today? Is that
then
it?
clarifying um assuming it's where that you just
I don't see what you talking. Have been the very first one. Miss Ford.
Yes, Miss Pray.
I don't see what you I don't see what okay, and do we got different words or something?
No, everybody
No,
has the same slide. There are 3 slides that came to your Canvas meal.
I got
yeah,
one. I got one from you today. It says activity. I click on
Yes.
the attachment, right?
Yes.
And I only got one thing. I press view. I only see one thing, one page.
Can you slide up? But we're just talking about the very first one right now, though. But you just would have to slide that
Let me unblur my screen. Hold on. Well, how do I do that? Okay, right here. All right. This one, man. Can you see it? Is that it? That's all I got.
scroll up one more.
Look, that's all I got.
So if you open that document up, there are just 3 slides. So it has to be a way for you to scroll up on it. It's just they're just 3 slides.
Yeah, I don't see it. I'm not. I tap everything on the screen. I don't see it.
And it might just be how your device downloaded it. So we're gonna bring everybody back in about 50 seconds. Everyone should be back in about 30 seconds.
I even put it up on my computer. I still don't have that.
Okay, we're gonna still go over here. Like I said, it might just be the way that it shows up on your device. But it's a PowerPoint, is what it is. All right, so someone share what is restating. You want to put that into your own words. Like, what is restating? You're trying to use the active technique of listening, and we're restating. So if you're explaining to someone what restating is, what would you say?
You just paraphrasing your own words that you understand and not what they had said without adding or taking away anything. You just paraphrase.
So we are repeating what they said. not the paraphrasing. So we're repeating what they said in just a slightly different way. So you brought up paraphrasing. What is paraphrasing? Where is what we said,
Changing the
right?
words.
What we
Basically, yeah.
go ahead. I'm sorry. Go ahead.
Basically, like you're regathering everything and putting it in your own words. Like if a patient said that, oh, my temperature was high, oh, I'm not feeling good. It's a lot of stuff going on, and basically you saying like, basically you overwhelmed with everything that's going on.
So
Like you,
restating you're saying is what the patient said. Paraphrasing, we're saying it in a slightly different way, both ways. But restating is what they said. Paraphrasing is what we said.
is what said yes, correct.
Okay, got it. Thank you all. So clarifying, what's clarifying?
Asking a question so that you can like better understand, make sure you understand what they're saying.
What did I just do with who was that was gave that response out? Remember, I just said, well, hey, are you saying that paraphrasing is what we said, and then restating is what the patient said? That was an example of what we just did. That led us right on.
Clarifying, basically you're basically getting an understanding of what was said. Clarifying meaning that you understand everything that was said.
Exactly. To make sure that we understand, because sometimes people will state something and the receiver misinterprets what was actually stated. So clarifying, asking that question in response to what the patient stated to be sure that we understood what the information that they were actually sending us or giving us. Because
Oh, did
there's
I
some.
say it backwards? I thought
Go
I said
ahead.
asking questions. I thought I said asking questions to make sure you understand what they said.
I'm repeating, and when I say something, I'm just going back and restating what we're saying. I bring us back full circle, you all. Mm-hmm. Yeah, so I'm not restating to disqualify or say what you're saying is incorrect. I always repeat, and that's something that you can do too. As we talk and discuss concepts, make sure that you're saying it like, okay, well, this is what, just to make sure that the concept that we're talking about is that you have that understanding. So I'm restating. I always restate. So, but it's not to say that you're saying something incorrect. So, restating, repeating what the patient has said in a slightly different way, paraphrasing, expressing in our own words what the patient said, and then clarifying. We are asking questions based on what the patient said, just to be sure that we understand. Because sometimes you're like, wait a minute, let me just make sure I understand what you're saying. Okay. And then what is reflecting?
I guess like repeating or acknowledging the client's feelings.
Okay. So all of these, we are just going to be repeating something. So reflecting is put it into words, the information that we received from the patient at an effective communication level. So just to make sure, again, making sure that we full circle, that we're on the same page, that what's being communicated is actually what they actually meant to say to us. Because remember, we're going to take this information and we're going to respond to it. We're going to go and do some interventions. We may go get, another healthcare provider. We may call the doctor based on what they're saying. So when we're making these phone calls and interacting with our healthcare team, we want to make sure that we're giving them the correct information. So what is minimum encouraging? Minimum encouraging.
Not saying a lot, but just enough
Mm-hmm.
to let the person know that you care.
Okay. So what did I just do? I used the word mm-hmm, and I was doing this right here. So
Like a
it could
short
be
response.
sounds. Yes, a short response. It could be sounds. Mm-hmm, mm-hmm. Tell me more. It can be those hand motions that
Gestures.
encourages the person to continue.
Mm-hmm.
Minimum encouraging. Right. So now tell me what you all put for remaining silent.
Quiet, like just quiet listening. Like an example of like when a patient has like diagnosed with a stage 4 cancer, it's just like, life threatening and they go to crying and stuff, just being there, just listening, let them know.
Simply being quiet. You're present, but you're not trying to give them the answer. You're not trying to ask them any questions. A lot of times, usually, the client has received information that's not favorable someone, they may have just lost a loved one, they may have gotten a diagnosis that they're not wanting, and simply just being there, present, without asking, doing our head to toe assessment, without saying, hey, I need to make this phone call, just being quiet. Good. Summarizing, what is that?
Now this is when you reword what you have to show you understanding.
And you're pulling out that main data. So you may have 3 points, based on this whole conversation that you and the patient have had, or you and the doctor have had, and you're summarizing. You just pull out those main points. So what is validating?
Basically, letting the patient know that you understand their feelings and that they're valid.
Okay. And then it provides,
like, basically restating what they said.
And if you have said something that's incorrect, then that gives that patient the opportunity to correct you. Because remember, sometimes the information that is sent, you got the sender and the receiver. Patient, we're having this conversation, but sometimes the information that was sent can be misinterpreted. So when we are validating, that allows the patient to correct any information that we summarize. We give out 3 points. So, okay, I understand. I think the example when I went around to one of you all were, the example was you acknowledged what the person had eaten or something for lunch or something. I didn't hear the whole scenario, but you were going back, or you were getting the client preferences for their meals. I think that was the scenario. And so the nurse was going back, restating what they said. And so I understand that you dislike tomatoes, potatoes, and bananas. So if that information was misinterpreted, I wrote my list down wrong, that gives that patient the opportunity to say, hey, I like potatoes and tomatoes and bananas. And so that gives them the opportunity to correct us. And so we do want to do that because sometimes information is misinterpreted. All right. So the next slide that you have, we'll just go ahead and do this one. What are some positive communication techniques? What are some things that we can do, per se, that is considered positive communication techniques?
Listening, eye contact, showing good eye contact.
Great, good. So early on, developing those therapeutic relationships. We're not bending the rules. We are being honest with them. We are, using I messages too. I am just making sure that I understand what you're saying. I want to repeat this to you. Let me know. Establishing that eye contact. While we do know in some cultures, sustained eye contact or glaring eyes, that's different from establishing that eye contact and looking away. So establishing eye contact is positive. Keeping your promises. In the event that you answer that call light and the patient says, hey, I need some ice in my water pitcher. And you say, well, I'll be right back, or I'll be back in 30 minutes. Make sure that that's what you're doing. And in the event that you can't, you want to delegate that task to someone else. Expressing empathy. While we might not understand truly how that person feels, but just letting them know that you are human and you do understand, and you do empathize with them. Using open communication, even if the patient is refusing an intervention or a treatment, we don't want to shut down on that client. Remember, they have the right to choose. We want to support them in their autonomy. Positive communication also includes clarifying information and then being aware of our body language. Is our voice tone, are we screaming? Are we frowned up? Do we have those glaring eyes? Are we sitting back and our arms are folding, the person, they're talking to us? So just be aware of our body language. We are doing a dressing change. If we know that wound has an odor or potential to have an odor, what are those things that we can do to prevent us from frowning and making all those sounds and responses to smelling that not so pleasant odor? Does that facility allow for fragrances, or what can we do? So just being aware of our body language also helps. So then we just talked about positive communication. What about negative communication? Do you think giving advice is negative communication?
It all depends.
You're the nurse and they're the patient. Nurse, what do you think I should do? You think I should take this treatment? Nurse, do you think I should take this medication? We want to give advice.
You
Or
really can't give them advice because you will be going over your scope because they got a right to choose. So if they don't want to do it and you encourage them to do it, then you're going against them.
okay.
I mean, I might be wrong.
And so you're not intentionally causing any harm, but giving advice is considered negative. We want to make sure that the client has all the information that they need to make an informed decision. You know, are there any alternatives to the treatment? You know, they need to know they have a right to refuse. They need to understand this medication is given for this. What are the side effects of it? You know, what's that patient teaching? And so, yes, giving advice is considered negative. But because they trust you, you're that trusted individual. So they're going to, but you always want to put it back on the patient. You want them to make their decision, and we want to support them in whatever decision they made. Because think about on the flip side, what the nurse said, I should have went on down and had that surgery. The nurse said I should have had surgery, and something happens, not necessarily, you know, a sentinel event where they lost a, you know, life, limb or something like that, but something happened that they were not expecting or they did not want to happen as a result of them having that surgery. And you, as a nurse, said, yes, I would have that surgery if I was you. What do you think is going to happen? More than likely,
I'm gonna blame you.
exactly. They may make that phone call to the board of nursing. They may do that complaint. So yes, but we don't want to give advice to them. But we do want to make sure our patients have enough information so that they can make an informed decision. And that goes back to false reassurances. Oh, 1,000 people have had this surgery done. You're going to be okay. We don't really know that. Yes, 1,000 people may have had this surgery and they haven't reported anything, but I'm not sure how you would, your response would be. So it's still going to be up to you, ma'am or sir, to make the decision. Now, if you need your doctor to come back in and go back over this information, then we'll have them to come back in. So, but we always, like someone just said, we want to put it back on them. Make sure, because it's their decision, it's their health care. We want to make sure, find out what do they even know about the disease process? What do they know about this surgery? So that we can make sure that they have all the information that they need so they can make an informed decision. All right, so I'm thinking you all have seen these 4 letters before. Have you all seen these 4 letters before?
Yes.
Yes.
Okay. You know what my next question is. So let's just do situation. In the chat, just put a response. If you had to give us a 1 word or 2 words, no more than 4 words. What is the situation? What are we talking about? In the chat, and drop it so everyone can see it. We're talking about the S part. We know the S part is used for communication so that we can communicate effectively. And it helps us to not to really forget anything. So it's a structured way to communicate healthcare provider to healthcare provider, you know, nurse to healthcare provider. And so when we're talking about situation, what are we talking about? Situation. Let's see here. See what's happening. A little mouse won't slide down, you all. Okay, what's happening? Okay, the current problem. Good, good, good. So let me do a scenario. We're going to administer medication to the patient in room 201. So the patient complains of a headache, and pharmacy later tells us that the medication that they put in the bin for us was mislabeled. So what is the situation in that scenario? The patient was given the wrong medication. That would be the why we're calling. And then, of course, we'll get more details as to what that medication is. But the part about us, it's time to get that patient the medicine, pharmacy called. But the reason that we are calling is because that patient received the wrong medication. So situation, what is the reason for the call? Why are we calling the healthcare provider? The why. So in that, someone I think mentioned it in the chat, we want to include our name, the unit, the patient name and the problem. Because we always want to give our name and the patient name, because there's several people that have the exact same name, first and last name. So we want to make sure that and here sometimes they'll ask for sometimes they won't ask for the date of birth here. They'll get that in the history part. But the situation, you are right, that's the why we're calling. So the background, they need a little history. What's their code status? Because we're calling because the client is without blood pressure, without heart rate. Don't you think the healthcare provider needs to know whether or not they are a full code or not? So yes, code status is very important. We want to give them their admitting diagnosis, the date that they were admitted, the current status. We always want those updated vital signs. What was their intake and output? As close as we can get that information. Medications, what allergies, what IV fluids they're on. And if they don't have any IV fluids, we just say, hey, they don't have any IV fluids. So that assessment, what do you think is going on based on the data? Do we think this is life-threatening? Is this the same, a different day, but the exact same thing the patient complained about, yesterday? Or is this something life-threatening? And then recommendation, goals of care. What needs to be done, including a consult? So if we're thinking of this client, they've fallen, they're complaining of pain. If we're thinking this client, more than likely, based on our assessment findings, something's broken, fractured, hey, we probably need to go ahead and get ortho on the call. Or this person has had a change with their heart rate. We're noticing this person's complaining of chest pain, that we've assessed that the pulse is thready, is fast, is irregular. We also may need to include cardiology in that. So what medication order, and does this patient need to be transferred? So the next couple of slides is we're talking about SBAR. This slide is just showing us again what we just read over just in one slide. So when we are changing shift, we still use SBAR. We're from nurse to nurse. We're changing shift. You're going home and I'm getting ready to take responsibility for this patient's care. So again, the SBAR allows us to communicate in a structured way, and it's such that we don't forget any information. So here we go. So the situation, we're changing shift. So that's the situation that's going on. So again, we give the admission date, what the patient's chief complaint was, and diagnosis. We give that background, medical history, their allergies, their code status. Now, some of these are the same, no matter if we're talking to the healthcare provider and or changing shift. The background is pretty much the exact same. When you're talking to the healthcare provider for the situation, something has gone wrong. Something's happening that we need to report, whether or not it's x-ray results, lab results, complaint of pain or whatever. But handoff situation is where someone mute yourself. We can hear your background. It's that admission date, the chief complaint, or the diagnosis. You're going home and I'm coming on. So the assessment information that you'll give me is the latest vital signs. And sometimes we'll go back and give the latest two sets of vital signs. So we can see if there was any fluctuations or huge changes in that patient's vital signs. Pain assessment, diagnostic studies, if they've had a lab, x-ray done, ultrasound, or what have you. Were there any preventative measures? Are they at risk for falling? And then we give the goals of care, what needs to be done. Because remember, it's 24-hour care. So if we have just received new orders for this client, but it's shift change and your relief is there, we let them know, well, hey, just got these orders and this is what's expected to be done, tomorrow or the next shift or whenever it's supposed to be done. A lot of times for something that's For example, a client could be complaining of pain upon urination. And most of the time they'll want that specimen. And then, if you're at that shift change, it just continues. You just pass that information on. And it's expected that the nurse will actually gather whatever is needed. So conflict resolution, this slide just talks about, even though, conflict is not our intent, sometimes conflict does exist. It's just almost like a natural part of life. But we want to take the time to listen, gather all factual information, their understanding of what should have happened, what actually happened. We may even have to get rule policies and procedures. We may have to pull out our scope of nursing just to validate, and so that people can gain understanding of what is expected from us. So effective communication, it can resolve conflict. Thinking about back to those, that restating, that paraphrasing, that effective communication. If there's some conflict there, we, that summarizing, it can help us pull out that information and do like a fact check. We want to make sure that we're listening, and we want to discuss it privately. If the patient is at the nurse's station, hey, I'd be glad to talk to you about this information in your room, because you do want to, we don't want to violate HIPAA. Nurses stations, people are coming in and out, visitors, other patients, they're getting physical therapists walking with them up and down the hall. So we do want to make sure that we provide that privacy for them. So I think this was no, this wasn't on the 3 slides that I gave. So the DISC script is what we can use too in the workplace to facilitate that communication. Who would have thought it was all of these many moving parts of communication, but it really is. And it does take effective communication in order to provide that best care you can for your client. We want to describe the specific situation of the behavior. We want to provide facts, concrete information. Well, I think that patient actually had on, or I think, no, we want to write down the information that's factual. Express how the situation makes you feel. What were the expectations? Because, a patient could be thinking, or a coworker could be thinking that, an outcome should be a certain outcome, when in fact, that's not the policy and procedure. Even though that's what I said initially about supporting the clients and their autonomy, establishing those therapeutic relationships, that doesn't mean we're breaking rules. So, but we do need to know, well, what were their expectations? Because they could have thought, well, hey, someone's going to stay at my loved one's bedside for 24/7. Well, no, we make rounds at a minimum of every 2 hours, and we'll be in regularly to check on your loved one. But we're in fact not the sitter. But if you want a sitter, so clarifying and gaining understanding of what that person's expectations are will help facilitate a solution. We want to get getting enough detail. Are there any other alternatives? Can an agreement be sought? Consequences should be stated in terms of impact in reference to the goal. So we want to stick to what's being discussed. We don't want to be talking about something else that's not even relevant or important to the issue that's at hand. So the chain of command is important. We need to know, in the event that, we're thinking that a coworker may be impaired, or one of our patients, they're being abused, or something has happened. We want to follow that chain of command. And all facilities have them. And once you do that onboarding, they'll show you their structure. But many times you do want to include your director of nursing, the chief nursing officer. We're having to, report things. If someone has, reporting abuse, you have that time, that small window when you have to, notify the family members, notify the DON, the what are those people called? Administrators, and those people that are on that chain of command. And then remember, in some facilities, long-term care facilities, you are the leader, the charge nurse, depending on, what shift it is. So you're a direct piece of that chain of command. So it's important to know, well, who are you reporting to? So just keep that in mind. So again, we're still talking about communication, you all. Got three different behavior styles. assertive, aggressive, and then non-assertive. All right, so let's go back here. So non-assertive is being dishonest. It's passing on the task. The patient has asked you, well, ma'am or sir, I wasn't really sure about, what the doctor said when he came in earlier about the surgery that he wants to do. Well, you can just let the next nurse know about it. It's not shift change. We're passing that task on. We're not notifying that healthcare provider that this client has more questions. We're passing that information on. We're not completing what is needed or should be done. And then being non-assertive is actually a barrier to communication. It slows down, it impedes communication from being effective. And then we have aggressive. It is being disrespectful. It's communication that belittles, make fun of, or put others down, makes a person to feel unsafe. The person may even become defensive because, they're thinking, okay, this person really does not have my best interest at heart. And it is a barrier. Being aggressive is a barrier to communication, effective communication. And then we have assertive. This is using the facts, no judgment, being honest with the patient. Patient states, well, the doctor says, everything is going to be okay if I have this surgery. Being honest. I am not sure. I cannot tell you that, ma'am or sir. I'm not saying that you won't be okay, but I, in fact, cannot just provide that false reassurance for you. So being honest, and this makes the patients feel safe. Yes, ma'am or sir. The rule is that we're supposed to have two persons in to provide assistance for your loved one. And they want you to just go ahead and do it and not wait on the teammate, the coworker. No, ma'am or sir, I need to wait because it's the best interest of your loved one that I have that second person to assist me with providing this care. And then that will, they may frown or be kind of resistant right up front, but they will like, oh, this person really does have my best interest at heart. So being assertive is being respectful, maintaining professionalism, not belittling, and then standing up for the client's rights. So if we see an order that has an unusually high dose on it, the order, all the parts are there. We have the right dose, the right medication, all the parts are there, telling us when to administer it, it's telling us the right route. But then we like, wait a minute, this right here, look it up. This dose is really high. Verifying, stopping what we're doing, making that phone call to that healthcare provider or that communication, however it's done, and just making sure, verifying that this is in fact the order that should be carried out for this client. And then we do want to keep in mind that while we are standing up for the rights and autonomy of the patient, making sure that we're not violating the rights of others either. Okay. So that was non-assertive, aggressive, and assertive. So communication is a huge piece. It's just like initially you would just think, oh, we're just talking, but there's so many moving parts. And if that communication is not effective, it is a barrier to that client getting that best care, receiving all of the best care from everyone on the healthcare team. So we're going to pause here. We have not taken our break, you all. We just over. So what we're going to do is nurses are the center hub for that collaborative part of the healthcare team. We function as, even though there are several people on the healthcare team, we are like that central part. And so they're going to always come back and say, well, ask the nurse, well, hey, does this patient have an appointment? Can we do physical therapy right now with this client? So we're that central hub. Nurses should provide safe care, remembering our medication administration rights. We should be questioning orders if they're unusual, if we think they're unsafe. We should be making our rounds and reporting those findings. Client safety is priority. Use the chain of command. Assist if no response from the healthcare provider. We serve as the client's advocates. And we want to clarify orders if needed. If does the order have all the components. We want to ensure that the client receives the best care and the adequate treatment. The patient has that right to refuse. We want to assess the client's understanding of what they know, the goals, the plans, and all of this will help establish that therapeutic relationship. We want to teach clients. We want to reinforce what was taught. Remember, we don't do that initial teaching, but we reinforce what was taught. We want to ensure that we're communicating effectively, and this helps promote patient safety. Remembering that hands off communication when we're handing off that client's care to the next person. Ineffective communication is a primary cause of sentinel events. Effective communication equates to active listening, empathy, developing trust, increased communication among the teams, improved team member satisfaction is an advantage of the interprofessional collaboration. So collaboration is the communication effective. We want to make sure that we're always asking that what information received in the manner that it was intended is what was actually communicated, actually what was communicated. Remember, we just talked about all those ways to that minimum, encouraging, restating, summarizing. We want to make sure what was actually communicated was actually communicated. Increase patient satisfaction. Think about it, a patient being discharged. Who needs to know? What information does that patient need to know? If that patient's going to a long-term care facility or rehab, what information do we need to provide? We want to coordinate that care. That coordination of care decreases or lessens the chance of that person being readmitted to that hospital. What is needed? We want to think about the resources, the medical equipment, the medications. What do the patient or what care does this patient need to have? What information does the family need to know? Does this patient need to know that they need to be checking their blood pressure? Does this patient needs to be checking their glucoses? Do they need a low sodium diet? And the list can go on and on and on. But we want to make sure that the patient has all of the information that they actually need. Making sure that it is appropriate. The information is adapted to the patient that it actually involves. How can we coordinate the care? We're working at the urgent care. What information should this patient receive when they're going home so that they can manage whatever it is that they have? We want to make sure that the information is in their language, in their first language, in terms that they can understand, and making sure that it is appropriate to and adapted to what the patient actually needs. We talked about passive, aggressive, and assertive. Those are different ways of communicating. We talked about the DISC model. We talked about S-bar. Make sure that we go back and know all those different components of that. We are mandated reporters. We talked about that. Advocacy and autonomy. We want to make sure that we respect the patient's rights to make their own decisions, their own choices. The nurse, we want to make sure that we remain respectful and courteous. And sometimes we might miss something. So, acknowledge if you didn't know or understand something, and then move forward with, providing that best care for that client. The client may have said, well, hey, I don't eat bananas, but then we wrote down that they like, bananas was a food choice that they like. So we might have just written that down incorrectly. So make sure that you're going back through your classroom required readings. Make sure you look back at your videos. Start going ahead and planning to attend your live exam reviews. So there was a question or concern about the group assignment. So make sure you're checking your announcements. That is where we will put the latest updated information. The group projects, make sure that you have checked the announcement that was placed on January the 12th, which you might be in a different group. Students change sections. Some students just change the class altogether. So once you actually access the document that says group project, there is a document there. Let me share my screen. Okay, so that document shows what group you're in, who you're in the group with, and it also shows your topic. For example, here, PN in the nursing process, navigating ethics. Then you want to go back and look at the rubric, take that topic. I'll share my screen here. So it's a group project. You all decide which parts and how each will participate. It might be that the person just pulls it all together and puts it in that PowerPoint for you after all the information has been received. It's whatever you as that group decide. This project allows you to explore the major things in practical nursing. So each of the topics are about practical nursing. So when you do your research, you will file, you'll pull up information regarding the registered nurse in the nursing process, advanced practice nurse in the nursing process. But remember, your topic is the PN in the nursing process. Okay. And so each group, you have your topic as a team. You want to research the topic. And when you do your presentation in week 10, you will, and it says poster, but remember it's a PowerPoint and it's a 5 to 8 minute oral presentation. So make sure that you're clearly explaining all the different parts of your topic. The summary of evidence-based information on the topic include at least 3 scholarly sources, no more. They want to be 5 years or younger, or less, the information that we're receiving, that you're actually researching. When you do your search, you're gonna probably pull up all kind of information, but don't go beyond 5 years. So if it's 20, let's see, that's 1998. We don't want that information. So use information that's within the last 5 years. Discuss on how this topic applies to the current PN practice. Remember, this is a PowerPoint. Okay, it's a PowerPoint. And so take each of your topics, whatever topic that your group is assigned, and you want to just break down and see, what does navigating ethics and boundaries in practical nursing. Take each of these components and actually talk about them and discuss them in your PowerPoint presentation. So meet early and often. You are given some time in class to meet, but that is not the only time that you can meet and finish this project. You should be meeting regularly and decide on how you all will communicate. Email, I would suggest having more than one way of communicating. And so that, because someone might not have, for example, Instagram or Facebook or whatever, however you all want to communicate. So, but whatever you all decide as that group, don't forget HESI is in week 11. That schedule is going to be a little bit different. Usually you take your HESI doing like the business hours and on campus. So if you're taking more than one class, make note of, what's going to be expected during week 11, which is your HESI. We'll see you next week.